And we've just gone 10 o'clock. Welcome, everybody. I'd like to extend a very warm welcome to everyone this morning from the Palliative Aged Care Outcomes Program. My name's Liana. I'm here with my colleague, Caitlin, and we're here to talk to you about frailty today. Before we introduce ourselves, I'd just like to do an acknowledgement of country and just really give a heartfelt acknowledgement of the Torres Strait Islander and Aboriginal people as traditional custodians of the land that we're meeting on today. And we wish to pay respects to elders past, present, emerging and future. And PACOP being a national program that we cover all parts of Australia. I'm down here in Melbourne and I'm on Kulin Nations. And Caitlin, would you like to introduce yourself and just acknowledge what country you're on up there?
Oh, thanks, Liana. So I am based up in Brisbane in the lands of the Turrbal and Yagara people. Caitlin Thorne's my name. I'm one of the improvement facilitators with PACOP based in Queensland. So welcome, everyone.
Lovely. Thanks, Caitlin. And my name's Liana Green. I'm an improvement facilitator in Victoria, and it's lovely to be here today. So let's talk about frailty. So today we're going to talk about frailty, some of the concepts behind frailty, some of the tips for assessing frailty in a way that captures those little aspects of frailty that we're really keen to pick up. And then Caitlin and I are going to have a chat about frailty and run through a case study, and then there'll be a time to ask questions at the end. So, Caitlin, I'm really keen to know from your concept. I know that you come from a nursing background. I'm just really keen for you to talk to us about some of those concepts about frailty and what you've noticed about frailty in your work.
Yeah, sure. So I think frailty can be a combination of things. When we talk about frailty, it can sometimes be that word that we associate with someone when we don't necessarily have any other diagnosis to give that person as to why their body's changing and why their health is changing. So frailty and what it looks like in older people can sometimes be, extreme fatigue and weight loss, changing in balance and gait, like fluctuating disability. So sometimes you'll see older people that have had really good days and really bad days, and no one really tends to know why, but they just go up and down. And it reflects this sort of multi-system decline and increases the vulnerability in older people. But whilst frailty itself can be a diagnosis, sometimes all of those different things and those changes may in fact be a little hint or a little flag to us that there's something else going on as well, which is why frailty can be a bit of a multi-dimensional sort of geriatric syndrome, but also a diagnosis in itself.
Okay.
Yeah.
Oh, lovely. So what I'm hearing from you, that frailty can be a diagnosis within itself, but actually can be an amalgamation of a whole number of different processes of decline that you're noticing in somebody.
Definitely. And I think it's also, it's quite interesting because sometimes it goes missed and no one necessarily sees it, but we know that that person's changing, but we can't really put our finger onto why they're changing and how they're changing. And frailty tends to be what we describe that as.
Okay, lovely. Thank you. I'm just wondering, Caitlin, if you can talk to me a bit about what you see as some of the impacts of, if an older person has frailty, what are some of the impacts that you may see?
Big one is probably falls risk.
Okay.
So particularly around the balance and the gait and the ability to walk. So obviously falls risk increases with that. People that are more fatigued, not feeling like they can get out of bed or move around. Obviously there's pressure area risk there. Nutrition's another big one with the ups and downs in the day and how someone is feeling. Obviously, someone may not feel like eating or they're not getting the level of nutrition to sustain themselves. So then weight loss comes with that, and that sort of goes hand in hand. So yeah, there's some of the adverse things that you can see as people become more frail, and just generally people increase their vulnerability increases. Okay. So they're just a little bit more fragile and vulnerable to infections and different things, and they sometimes require a lot more care, and you can sense that an older person is starting to become more complex as their frailty increases.
Okay. And also what I'm hearing is that susceptibility to illnesses, susceptibility to
100%.
Other aspects of life that may...
Any other little stressor that might impact someone, that stressor is going to be more difficult for someone that has a higher level of frailty than another older person, for example.
Okay, fabulous. Thank you. And it really, what I know coming from a social work perspective is how much quality of life can be impacted by,
and the mental
someone's.
health and psychosocial
Yeah.
impact of that as well, when someone just feels like they're just too tired or unable to get out and participate in life as much as they used to.
Yeah. Oh, great. Thank you. Thank you. So, and what I'm really fascinated about what you're saying, Caitlin, is that how multidimensional frailty is. I'm wondering if you can speak to us a little bit about that aspect of the difference between the physical frailty and cognitive frailty.
So a lot of what we just spoke about before was, were physical symptoms. So, the falls risk, not being able to get out of bed, that sort of thing. And physically, people often notice, or if you haven't seen an older person for a length of time, you'll be able to see, their physical changes more obviously. But what tends to be missed quite often is the relationship between sort of someone's cognition and how that impacts frailty as well, and that cognitive changes and dementia impacts that frailty. So the increase in the changes in that space increases someone's frailty and vulnerability as well.
Oh, lovely. Thanks. So we're looking at that physical and cognitive processes often happening side by side, or they can happen independently.
Which is why when we do what we do and we start talking and teaching so the Rockwood Clinical Frailty Scale, we weave in that cognitive component as well, because sometimes, in aged care particularly, people who are around older people all the time tend to put their blinkers on, and we forget that those people with cognitive changes like mild dementia, moderate dementia, they actually have quite a high level of frailty, even though physically they may not seem it.
Okay. Oh, lovely. Thank you. I'm just keen, if we move on, thanks for that, Caitlin, because I'm keen to move on and talk about that. You spoke about the use of the Rockwood Clinical Frailty Scale to assess. And I wonder if we can talk a bit about how hard or easy it may be to identify when someone's actually declining due to frailty.
Well, I don't know. Some situations can be easy and some situations can be very difficult. Obviously, if you've got someone that's had a really acute event or an infection of some sort, and they've gone to hospital and they've come back and they were nowhere near the condition they were when they left, that is really easy to recognize. So, some of those top images on that slide, you can see that terminal illness, that instant drop. Some of the other changes in someone's frailty can be a lot more subtle. And this is, I suppose, when I was speaking about people having their blinkers on and not necessarily realizing it, is because those changes are not really, they're a bit non-specific, or they're so subtle that if you're around someone every day, they're not going to jump out at you and ring alarm bells. So which is kind of the bottom right image there, that frailty. The other component is, the organ failure image that we can see there as well, is that someone has a little episode or an acute event and they decline a little bit, but when they stabilize again, they are nowhere near the condition that they used to be. And that consistently happens over and over again. And that can also, be a part or a way that someone's frailty can continually, worsen, or someone becomes more vulnerable as those changes happen.
Lovely, thank you. And that's a great segue to our next slide, which gives a really great visual representation of that, of the sense of that when somebody, has a more robust physicality, that actually they might easily recover from a minor illness. But actually we know that from people who have frailty that they may not recover in the same way. It may take longer. Can you speak a bit more about that, Caitlin?
I think this image in particular is really helpful, because it's got that line around when someone's independent and when someone becomes dependent. And seeing the change in the fact that those people, when they do have a minor illness and that episode, they're not going to get back to where they used to be, but also over time, they drop below that level of independence, that line. So depending on how many episodes, all of a sudden, there'll become a point where they won't bounce back to where they used to be above the line. So that's how, and again, that can sometimes go a little bit missed, because we start investing more people power into the care of people who are progressing along those stages, but we haven't caught that early enough, I suppose, to identify when that point is that all of a sudden that person's gone from one assist to two assist, or, they used to be able to walk with their wheelie walker and now they need one assistance all the time with their wheelie walker because they had an episode and something happened and they're not like they used to be before that episode.
Yeah. And what speaks to me really overtly about this slide is that it's really pretty subtle, isn't it? Like when you're looking at someone's decline, you might think, yeah, actually they're back to where they were, but it could be just these subtle changes repetitively.
And that red line as well, it's taken a lot more time to get back to some sort of functional independence than prior with the green line there.
Yeah, it's a really great example of visually looking at some of the experiences that people who have frailty, show in their trajectory. Okay, that might be a really great chance then, Caitlin, to move on around how we assess frailty. Can you speak to a bit about some of the processes that we can use to assess frailty so we can pick up those incremental changes a little better?
Some of the things around frailty can be quite simple observations like mobility and how much assistance someone needs with their ADLs, like having a shower, setting up and eating their meals, falls as well. Obviously, like the Rockwood Clinical Frailty Scale has got some suggestions in each of those numbers, which I think we've got on the next slide or soon, around fatigue's another big one. How often someone is participating in activities, how often they can, or how well they can manage, their home. Some of those earlier numbers, so the 1s, 2s, 3s, and 4s, talks about, how well people can manage their life and their activities through the day. But some of, as we progress along the scale, we're talking about how much assistance someone needs to do things like sort of walking and shopping and housework, and other activities of daily living, I suppose.
Fabulous. And I just want to give a point out that when we're looking about the Rockwood Clinical Frailty Scale, that we've got the purple lanyard card here, which is a great resource to carry with you at the bedside. I'm just wondering, as we before we get into the case study, Caitlin, I wonder if we can talk a bit about some of those tips that we have that can really help us use the Rockwood Clinical Frailty Scale to its optimum, and some of the things that you use in your
I think one of the take-home messages when we're looking at the Rockwood that I like to tell people, because sometimes I find that team members that we're teaching this to often mark people on the Rockwood a lot better than what they necessarily are, because again, they're so used to seeing these people, they forget, particularly around their cognition, that someone has a mild dementia, for instance. So quite often when we're reviewing a PACOP assessment or a profile on someone, and I see a resident that say has a Rockwood of 3 or 4, I'll question that and go, tell me why you've done that. And it's quite often a team member will go, oh, but they're really good. However, when we pick that apart and we think about, could that person do basic ADLs and look after themselves when they're back in the community, quite often someone will go, well, maybe not, because they need me to set up breakfast and they need me to help with the laundry, and we tend to forget how much support that these people actually need, and then also we tend to forget that sometimes there are cognitive changes, and that automatically puts people in a more vulnerable state, and when we're looking at the Rockwood, that immediately puts someone at a level of 5 because they have a mild dementia or mild cognitive changes.
Fabulous. And I know that when we've got resources that help understand about how to assess people who have dementia for frailty within PACOP.
Because I think again, just because someone physically isn't presenting as frail doesn't necessarily mean that they're not living with a life-limiting illness. And I think that's another great take-home using the Rockwood, is that, if someone does have a mild, moderate, or severe dementia, they are living with a life-limiting illness. And that is impacting their quality of life and their longevity and how long they are going to live for. So sometimes we need to step outside the bubble. Like if we are conditioned to working in a dementia unit, for example, all the time, we need to remember that all of the trajectory of people who are living with a dementia is only going in one direction, and to use that opportunity to step outside and look outside the box, to think about what planning and what we need to put in place for those individuals.
Sounds fabulous. It's probably a great time now, Caitlin, to jump into a case study, because I think we've gone over some really great sort of ways of looking at it, talked about the Rockwood Clinical Frailty Scale. Let's see this in action. So we've got this case study here. We've got Enid. So Enid's 94, and she's just been admitted into residential aged care because of incidents of being increasingly forgetful and leaving the stove on quite regularly at home. She's been forgetting things daily, even hourly, forgetting family members' names, when she last had a shower, when she last had a meal, things like that. She's got osteoporosis, experiences discomfort. She's using a 4-wheel walking frame, quite unsteady on her feet at times, had a hip fracture, but still enjoys walking every day. She really loves interacting with staff. She's in our dementia unit. She likes being busy and engages in activities quite readily. And she's following staff around quite a lot in the dementia unit. And I'm just putting that out there. Using the Rockwood Clinical Frailty Scale, what score would you give Enid? Should we talk about this, Caitlin? What do you think?
We should indeed. So I suppose Enid is a reflection of many people that I have cared for previously. And again, like we were saying before, people who are quite physically okay for the time being around, for example, a dementia unit or an aged care home, we tend to forget that they have quite high needs because they're physically still able to walk around and do things and participate. So Enid, you can, in her story, she was still participating. She was the sort of person that you could talk to all the time, that would, check in at the nurse's station and have a chat. And she was still quite physically okay. But the standout things here is that, she can't remember when she last had a shower. She can't remember if she's had a meal or not. She's got some quite osteoporosis, some other health changes in addition to cognitive stuff that is progressing. So there's a few flags there that she's probably got quite a lot of needs, really, and is maybe a little bit more in terms of cognitive changes, a little bit more than mild. I think given that she's forgetting people's names quite regularly and forgetting things even hourly, that's giving us a little bit of evidence to think that she's a bit beyond mild dementia. It's probably more sitting in the moderate dementia.
Okay. And so just looking at those tips that we have about using the Rockwood Clinical Frailty Scale, about considering, what are Enid's energy.
That first, and I think this is where, Liana, some people get a bit thrown because her energy and physical fitness is probably quite okay for someone of her age and at 94, that she can still wander around and sit through the whole day and participate. So energy and physical fitness for her maybe not a flag. But when we're looking at disease symptoms and dependency and cognitive status, they're the three things that are really going to change and impact this Rockwood Clinical Frailty Score that we give Enid.
Okay, wonderful. And we can see that some of those things, what I'm hearing you say, Caitlin, it's bringing together all those different elements of, not just the energy and physical fitness, but actually what active disease symptoms are going, and her diagnosis of osteoporosis, so falls and broken bones, also a level of dependency. What I'm hearing is not just physical dependency, but that cognitive dependency of reminders, needing reassurance from staff quite often.
100%. And I suppose the other thing with Enid's story is as well is if Enid, for example, started changing with her energy and physical fitness, and someone maybe would look at her and go, oh, but she's just elderly and frail. The flip side, like we spoke about at the beginning, is, well, what is actually underlying that? So there might be, as we know, older people not only typically have one diagnosis, but many other diagnoses that make up their complexity in healthcare. So, the other side to that is, well, what other disease process, if she changes and progresses and becomes more vulnerable and frail, what else is going on in her body that is changing in addition to her dementia?
Fabulous. And it's a really good tool, isn't it, for being able to pick up those different aspects of frailty. Wonderful. So let's look at what score that we would give Enid. What score would you give Enid, Caitlin?
I would have got, 6, moderately frail. And like I said before, most of that is informed by her cognition, not so much her physical fitness.
Okay.
So yeah, definitely at least a 6.
Wonderful. And it'd be interesting to for you it's watching this later or at the live to thinking about what score you would have given Enid and your thinking behind that.
I don't know whether there's anyone else online that would have thought any different or wants to put anything in the chat, but or maybe you're sitting there thinking about a resident that this sounds very much like as well. But yeah, certainly feel free to put things into the chat and let us know what you would have scored Enid.
And it could be a great point of discussion in communities of practice coming up in this next month as well around, looking at scoring frailty and the different nuances of that. So I'm just mindful of the time. I'd really like to just summarise from what I've heard from you today, Caitlin, because there's been you've really shared some amazing ideas here. What I'm hearing from you is that frailty is really multidimensional, that there's a whole range of different issues that contribute to, I guess, what we would consider for someone to have frailty across both physical and cognitive aspects. And 100%. That it's important to consider physical and cognitive aspects in terms of frailty.
Yeah, definitely.
Okay. Yeah. And just that concept of that reduced resistance and the increased frailty, the increased vulnerability to illness, I think is really important as well. That why it's important to pick up to diagnose someone who may have frailty, because actually they could be rather more vulnerable for illnesses as well. And to pick that up I can imagine is really quite important.
I think also in historically in aged care, we've never used, well, some may or may not, but going back to when I first started in aged care, when I was, many years ago now, there wasn't necessarily a measure. Like we spoke about it anecdotally. We knew who was deteriorating and who became more vulnerable or who got a little bit sick and wasn't as good as they used to be. And we used to chat about it, but it's not like we used to be able to measure it and have that measure inform an action. Yeah. So I think that's where we've progressed in aged care, that we can actually because it's not like we didn't notice it before, just we never had a standardized way of measuring it and doing something about it and calling it out for what it was and having a name for it. So I think that's where we've progressed significantly in the aged care space, and now we can actually have these measures inform and prepare and so we can care plan and put things in place for these people and buy ourselves time so we can see and track the progress of someone and know that we have time to do something and prepare as they change.
Absolutely. I think that's a great beauty of the PACOP program, isn't it? Using that assess, respond and plan protocol. And, I often have that saying that the enemy of a good death is a crisis. And any time that we can gain back to plan for people to age and die well is really very,
and even having something to start a conversation. I think, because often sometimes we can get a little bit fearful of families or having that conversation with loved ones about the fact that they're an older person is changing, whether that be their mum, their dad, whoever. But I think if we can normalize that and be able to talk openly with people about how someone's frailty is changing or someone's becoming a bit more vulnerable, then we can, again, buy ourselves that time and have that conversation when we're not in crisis mode, because that can make for a much nicer experience for everyone, for staff, the nurses, the families, and the resident themselves.
Absolutely. And I always think it from a social work perspective that sometimes people need to have a conversation several times, that as staff in aged care that you may see changes in a different way that family members might do, particularly around frailty. And it gives you the opportunity to have those conversations several times, isn't it, around, preparing and what you're noticing as aged care staff.
Definitely.
Fabulous. Well, thank you very much for that, Caitlin. I really enjoyed our conversation today. Thanks very much for that. I'm wondering if there's anything in the chat, anything anyone wants to share or be part of the conversation today
that are online.
Nothing's coming up.
Oh, Helen.
Helen. Hello, Helen. Would you, I'm just trying to see. There we go. Helen, would you like to ask your question?
You can unmute Helen if you like and have a chat.
Hello, Helen.
Hi, can you hear me? Can you hear me?
Yes, Helen, welcome.
Oh, thank you. Just saying, and thank you for that. It's really good kind of discussions and an overview. I suppose just building a little bit of what you said at the end there, Caitlin, about a lot of the, little bit, not always a lot, is that pushback saying, well, we know this. Why do we need these measures? How is it going to help? How is it going to help us know the care that we're providing in doing that? And as you said, that whole understand that whole person, joining all the dots, I suppose.
Yeah.
What's your response in that sort of say? We've done a little bit of that, but it'd be great to hear, because that's what people, we're busy. Groceries are giving us another assessment to do. We know this anyway. We can't see the benefit of it. That sort of stuff is some of the comments that I've been hearing.
I think one of the big benefits in actually having a tool to measure frailty is that, it's I hate to go a little bit data nerd, but it's to be able to use that information and numerical information to understand your resident cohort. And yes, we do know these things. And like I said before, anecdotally, we've done this and been able to talk about it historically for many years, and that's what aged care we've done really well. Just we haven't necessarily been able to extrapolate and describe with numbers and from a quantitative point of view what frailty and what changes and measures of time and change, what that looks like in the aged care space. I think that is what, using what seems like on the surface just another tool, that's what it can gain us, I think, and be able to prepare us from day one to give someone really gold standard palliative care, rather than that last week or that last month of someone's life where we know that someone's getting pretty crook or pretty frail, whatever we want to say about them, because they've changed so much in the 2 years that they've been living in our aged care home. I think if we look at it from day one and we're able to measure and build that part of our everyday care that we do for people, that can inform us so much better, and also gain us the time up our sleeves to do the things that we need to do, like have conversations, like look at someone's ANAC, like talking to the doctor and talking together as a nursing team about how someone has changed in a 3-month period. I think that's the big benefit in being able to use such a tool in this way.
Yeah. And thanks, Kat. And I remember hearing a gerontologist refer to the bouquet of symptoms around aging. And that sense of when little changes happen across a range of areas, it's really hard to identify that, even if you know someone really well. And the benefit of using a tool is that capacity to step back. To step back and take a holistic assessment and looking at each little element that may have only changed a tiny little increment, but collectively it's creating a big picture of change that can only be gained from perspective, stepping back and looking at the entirety.
Yeah, and it's creating that path and mapping that experience or those changes out, rather than relying on anecdotal, words that describe, not, the qualitative people in the world like Liana, not saying that that's not powerful, but when we're actually, looking at it from a quantitative point of view, being able to see those changes step by step over a 12-month period in someone's health and frailty is, just a different structure really to give to that.
Yeah. Wonderful. Thanks, Helen. That's a wonderful question. Very much appreciated. I'm wondering if there's any other questions out there. No hands going up? Well, that might be a wonderful time for us to end today. Thank you, everyone, for participating today. Thank you for coming along and listening. Thanks for those of you online who are watching later. It's been a delight to chat with you today, Caitlin. Thanks for sharing your wisdom. I really do want to encourage everyone who's here to continue to engage with the information we have here about PACOP. We've got our wonderful YouTube channel, which this will be uploaded to later, and a whole range of resources. So I do encourage you to continue to reach out, use our resources online, and reach out to us as improvement facilitators and workers at PACOP. But otherwise, thank you so much for your time and attendance today. It's been wonderful to share the ideas around frailty with you, and wishing you a wonderful day.
Thanks, Liana. And we'll share the slides and any other information on an email, and keep an eye out for our next morning tea talk in October. And we'll circulate the date for that as well. Thanks, everyone.
Thanks. Have a great day.
Bye.